Hello friends, Dr. David Katz, and if COVID isn't quite done with us yet, then I guess we're not done with these reality check videos, so let us carry on. Last time I conjectured based on extrapolation that we might be near the end of the pandemic in the United States, and that still might be true. In particular, I noted that when the pandemic does end, we're not going to know for quite some time. There are going to be sporadic cases. The anxiety will go on long after the threat of serious infection is over, or at least long after it becomes a rare thing. And so it's still possible we're very close to the end game. On the other hand, we are seeing pretty widespread elevations in case counts. So I think the safer presumption at this point is that the pandemic is not yet over, but it's very different. And I would argue that we seem to have a mulligan on our hands. All of my prior videos, my prior columns make the case that the United States has been a masterclass in pandemic mismanagement. We've done everything wrong. We've done it wrong in both directions. We failed to protect the vulnerable from the virus. We overprotected everybody else and caused social upheaval and transmuted the social determinants of health into social determinants of death. So we did the very opposite of what I was advocating. I was advocating total harm minimization by matching protection to the level of risk. We achieved total harm maximization by locking down indiscriminately, haphazardly, by opening up indiscriminately, haphazardly, by not adequately protecting those who most needed protection. So we went through the pandemic to date in the United States with high case counts and high casualty counts by global standards. What we're seeing now, though, is a pretty widespread spike in case counts, and this is true throughout the United States, but it's also true in other parts of the world, but without a concomitant elevation in casualty counts, at least thus far. So there's a much wider splay between cases and casualties, and I consider severe complications, hospitalization, or death, and any really adverse effect of COVID, a casualty. So I'm not just talking about death. We're not seeing hospital systems in the United States overwhelmed. Those states that were particularly hard hit recently, actually, ICU occupancy is declining as best I can tell. And there's so many data sources about COVID, and none of them is perfect. So it's really hard to have reliable intel on a daily basis about all of the key metrics, and those include cases, hospitalization, ICU occupancy, death, complications. I'm doing the best I can, and based on all of the data that I can access, it looks like we have a huge divide now between cases and casualties, which we did not have at the beginning. That's good news. It's an opportunity to get it right between now and the end of the pandemic, if the end of the pandemic is not imminent. And again, it could yet be. I remain hopeful that it might be, that we may be very close to the end. But there's some reasons to think that maybe we have a ways to go after all. And the first attempt at understanding that would be an attempt to explain why might we have this marked rise in cases now, and how can we ensure that if we are seeing increased spread of the virus now, it does not translate into a spike in casualty counts. It does not overwhelm the medical system. It does not cause another surge in fatality. So I think there are three potential explanations for a rise in case counts now, and all of them, by the way, are predicated to some extent on the fact that we're testing much more now, massively more now, orders of magnitude more now than we were at the beginning of the pandemic. So we might have had a very high number of asymptomatic cases in the early going. We would not have known. We weren't doing testing in asymptomatic people. And that invites the first of my potential explanations for the rise in case counts. Maybe some portion of this is reinfection among young, healthy people who had mild or asymptomatic infection back in March or even February, and we didn't test any of them. When I wrote my New York Times op-ed piece, which published in March, when I wrote it, we were on the brink, but had not yet sent young people back home from college campuses all around the country. When we did send them home, we didn't test any of them. there might have been widespread asymptomatic circulation of SARS-CoV-2 in that population at that time. We wouldn't know. What we do know now, though, is that reinfection is possible, and that it appears to be most probable after a delay of months, well, it's quite a few months since February, and in people who had mild or asymptomatic infection the first time around, and that's most likely to be young, healthy people. So with very widespread testing on college campuses now, and virtually no testing on college campuses back in February and March, we may have a significant contribution to the new spike in cases of reinfection. And it's relatively inconsequential because it's overwhelmingly asymptomatic, provided it doesn't reach people who are in high-risk groups, and we'll come back to that in a minute. So one potential explanation is some of this is reinfection, and that's important because you could imagine if people who have mild infection are prone to reinfection after months, we could be chasing our tails forever. We could say the pandemic never ends because every few months we test young, healthy people, we find asymptomatic cases, and we say, until we stop finding these case counts, the pandemic isn't over. That's misguided. But that's one potential explanation. Another potential explanation is that people who have partial resistance to SARS-CoV-2, because they have had prior exposure to common cold coronaviruses, and I've talked about this issue of partial native resistance in prior videos, if they have a higher exposure dose now, that can overcome this partial native resistance, because to be clear, it's a partial resistance. So if you've had common cold coronaviruses, it's not as easy for you to get SARS-CoV-2, but if you get a big exposure to it, you can get it. Well, if there are more exposures indoors now, as we migrate from summer months to fall months, that concentrated exposure dose could lead to people who had partial resistance and therefore were acting as if they were immune to SARS-CoV-2 up until now, to become susceptible. And it's unlikely they would get severe infection because, again, there's a partial resistance, but they may show up as cases now without showing up as cases before. Another contributor to that could be failure to practice the common sense precautions. So if people are experiencing pandemic fatigue and not using masks and not doing distancing, the exposure dose to the virus could go up, and people who have partial native resistance could find that level of immunity overwhelmed, and they could find themselves included in the case counts. And those, by the way, are two good reasons, and good in the sense of happy news, two good reasons why we might be seeing a spike in case count. So reinfection, prone to be asymptomatic in young, healthy people, and higher exposure dose among people with partial native resistance, also not particularly prone to severe infection. The third potential explanation for the spike in case counts also relates to pandemic fatigue, and that is that we are exposing ourselves to the virus, those of us who carefully hid away from it up until now. And this would suggest that some significant part of the population actually did manage to safely hide away from the virus up until now. That seems somewhat implausible to me, given our want of clear national guidance on the topic, but maybe individuals did take matters into their own hands, and maybe individual level precautions were far better than national policy. And so if some very high number of millions managed to stay safely away from the virus, and in my prior video I suggested, and in my prior column, suggested that number could be more than half the population, maybe 190 million people, and if they are now coming out and exposing themselves because everybody's had enough of this, we could be seeing cases among people not formally exposed. That third explanation, so we've got reinfection, we've got overcoming partial native resistance with higher exposure dose, and then we've got initial exposure among the formerly sheltered. That third one comes in two variants, and those two variants are A, where that's basically indiscriminate. Everybody's exposing themselves no matter what their level of risk is. So the people who sheltered up until now, even if they're over 70, over 80, if they have heart disease or diabetes, are now becoming exposed to the virus. Or B, people who know themselves to be in the high-risk group are still being careful. So younger people, healthy people are saying enough is enough and allowing for potential exposure to the virus. But our older loved ones who know they're at very high risk are still being careful. So some combination of these would account for an elevation in case counts without an elevation in casualties. The only one that would tend to drive up casualties is if our older loved ones who have the risk of age and or people with chronic disease are not being careful. But we're not yet seeing a spike in hospitalization or a spike in fatality. And this suggests that maybe people have learned the lessons of the pandemic. Those people at elevated risk know they're at elevated risk and are being careful. And that highlights for all of us the opportunity to exploit this mulligan. And the timing of this, as I sort of take stock of where we are relative to the end of the pandemic, I reflect on my extrapolation that maybe it's pretty close, but I have to now allow for this rise in case counts. All of this coincides with the release of something called the Great Barrington Declaration. I will attach a link, of course. And this is the work of several colleagues in epidemiology, one from Harvard, one from Oxford, one from Stanford. They got together in a home in Great Barrington, Massachusetts, hence the name. But what they call for in this declaration that at the time I record this has been signed by over 5,500 experts in public health science from around the world and well over 11,000 medical practitioners from around the world. What they call for is focused protection, which is another way of saying risk stratified interdiction in the service of total harm minimization. In other words, the very thing that I advocated for at the start of all this. Total harm minimization means we care both about the harms of infection and the harms of societal lockdown and social determinants of health. And what I called risk stratified or vertical interdiction, they call focused protection, but it's the same thing. It basically says, let us match the level of protection to the level of risk. Now, up until now, we've blown that opportunity. And again, in the United States in particular, we got it wrong in both directions. Overprotected those who didn't need protection and maximized the harms of lockdown, failed to protect where protection was most needed, and we maximized the harms of infection. But if we have some miles to go between here and the end of the pandemic, it creates an opportunity to set these policies to right and match the level of protection to the level of risk. So it needs to be much better protection than it's been to date for people who are elderly, people with chronic disease, especially nursing home residents. But it needs to be massively less protection and lockdown for populations in low risk. So for example, there's all sorts of talk about closing colleges back down because of case counts on college campuses. But if these cases are overwhelmingly asymptomatic, why would we shut the colleges back down? Why would we incur that level of disruption and upheaval when in fact the virus in those populations is doing nearly no harm as best we can tell? Now, if we take advantage of this mulligan, the policy responses would involve risk stratifying the population, matching our policies of protection, but also careful monitoring. We are doing much more testing now. If anything, we're still doing too little, certainly not too much. Careful monitoring and a bracing dose of humility, because there are concerns about how this virus could affect any given population that are not fully resolved. One of the issues that keeps coming up is what about, for example, cardiac complications in young people? They appear to be extremely rare, and by the way, they occur with other infections and other pathologies too. But if it turns out that we are seeing a spike in cardiovascular manifestations of COVID following asymptomatic infection in college students, that changes the equation, right? That requires humility. We have to be willing to adapt our policies on the fly if it appears that we are not appropriately matching protection to the level of risk. But again, thousands, literally thousands of public health scientists and medical practitioners agree that we've gotten this wrong by overprotecting those who are almost uniformly going to have a mild or asymptomatic bout of SARS-CoV-2 and experience no long-term complications, and underprotecting those who are highly vulnerable to lethal exposure. So we can now fix that by doing focused protection per the Great Barrington Declaration. So either the pandemic is nearly over, in which case, speculation about the right policies no longer matters very much, because before we implement any improved policies, it'll end. That would be great. But again, the magnitude of case count elevations and the distribution of case count elevations makes me think I was wrong about the timing of the pandemic ending. It looks to me like it's not over yet, but it is different. This wide divide between case counts and casualty counts is an opportunity. It's a mulligan. It's a chance to get this right the second time around. And now, as at the beginning, the way to get this right appears to me to be total harm minimization by means of vertical or risk stratified interdiction policies. In other words, focused protection per the Great Barrington Declaration. I will attach relevant links. I'll get back to you when there's more to say. But for now, until next time, stay well.